My name is Lawrence Rosenberg, and this is the Alpha Human Podcast. On today's episode, we're going to talk about what your doctor is not telling you about your cancer. First, let me say up front that I am not a doctor, nor am I a medical or healthcare professional, and the content of this podcast and any information, advice, opinions, or statements within it are not intended and are not to be used as a substitute for professional medical advice, diagnosis, or treatment, and you should not disregard or delay in obtaining medical advice for any medical condition you may have, and you should seek the assistance of a healthcare professional for any such conditions, and always inform your doctor of any changes that you may make to your lifestyle and discuss these with your doctor. Okay, with that out of the way, we're going to get into my own personal journey with cancer, with kidney cancer, because I was diagnosed almost 7 years ago. And at the time, we'll get into it, but we had a large tumor removed from my left kidney. And recently, that cancer showed up somewhere else, and we had another tumor removed, right? So we'll talk about all of this. Now, I want to get into it with everyone because, I mean, look, I've done a lot of podcast episodes over the years, and I've never discussed this, but I think it's come to a point now where I've learned so much through my own personal journey that I want to share some of this information. And again, this is about what you're going to hear today is about my experience. And I figured, you know what, I've dived so deep on research over the years, and especially recently since this cancer showed up somewhere else. And I've uncovered and identified so much that I thought to myself, you know what, now's the time to talk about it publicly, and mostly to share what I've learned through this experience, because I hope that the information that I do share will help somebody. And even if I only end up helping one person with what we're about to talk about, and by the way, what we're going to talk about in probably 5 or 6 episodes, because what I'm going to tell you throughout this journey and what I've learned, there's no way we can do it in one podcast. So I'm going to break it up into 5 or 6 or 7 different podcasts, and we'll take it from there. But today, we're going to talk about the first part of the journey and where we kind of get to a point where I end up saying to myself, that's it. I've got to share some of this knowledge. Okay, so again, diagnosed with kidney cancer almost 7 years ago. How did this come about? How did the diagnosis come about? I had a swelling in the left side of my groin, right above the left testicle. And what happens is I feel this swelling, and I could feel the veins above my left testicle swollen. I mean, they were abnormally large, right? And I could feel something was going on there. So I went to the doctor, and the diagnosis that he gave me was that I had what's known as a varicocele. Now, what's a varicocele? That's a swelling in the scrotum that's caused by a collection of abnormally large blood vessels, right? The veins in your scrotum. And it's due to dilation of the testicular vein, which drains the scrotum and testicle, and is a form, when it's swollen, it's kind of like a form of a varicose vein. So the right testicular vein, just so we're clear here, you have 2 testicular veins, right? You got 2 testicles, both veins. The right testicular vein connects to the inferior vena cava, which is the lower half of the vena cava, and that's the largest vein in the body. And the left testicular vein, that connects directly to the renal vein. All of it connects together with the kidneys, but those testicular veins, one's going in directly to the vena cava. The left one's going into the vena cava, and the right one's going into the renal vein, which goes right into the kidney. The point is this: the main blood vessel that carries blood from the kidney to the inferior vena cava is that left testicular vein. Okay, that left testicular vein. And any pressure that's either on the left testicular vein or the right testicular vein, any pressure within those veins will cause blood to collect in the scrotal blood vessels, or it may cause blood to collect in the scrotal blood vessels that connect to the testicles. And that could lead to this varicose vein known as a varicocele. Now, in rare cases, so if anyone listening, right, is feeling that kind of swelling, you should know that in rare cases, this could be caused by a large renal tumor that compresses the testicular vein. As you can imagine, given the testicular vein's proximity to the kidney, right there, if there's a large tumor and it's hitting that testicular vein, that's where you're getting the issue. But again, that's rare. In fact, a varicocele occurs in approximately 1 in 8 men, and it is usually first noticed between the ages of 12 to 28. And the vast majority, around 90%, occur on the left side. And that's exactly where I had my varicocele. And so this is a very common thing, this varicose vein in the testicles. In fact, here's the crazy thing. When I was 18 years old, I felt this as well. It was nothing even close to what I felt 7 years ago. But when I was 18, I felt that, there was just a tiny bit of swelling in those blood vessels right above the left testicular vein. And I went to a doctor then, and they told me, yeah, it's a varicocele, right? So I kind of knew I had this thing, but it wasn't noticeable for the most part. And then 7 years ago, it blows up, like there's this massive swelling, and now I notice it big time. So first off, if anyone listening to this ever feels a swelling in the groin and the veins leading to the testicle, don't ignore it, right? Get yourself checked out by a doctor immediately. Again, it's rare that it would be what I had, but it's a possibility. So here's what happens. I go to the doctor, doctor checks it out. He says, hey, it's a varicocele, explains what that is, right? I already know what it is, but he kind of explains what it is. And he says, what he also does, by the way, is he lays me down and he starts feeling my abdomen. He starts pressing with both hands, both sides of my abdomen. And what he's telling me doing, he's feeling the kidneys. And he's like, sometimes a varicocele could be related to something going on in the kidney. So I'm gonna get you checked out with a specialist where they'll do an ultrasound, right? We just want to make sure everything's all right with the kidney. So what's really happening here, which I only figured out later on, is that when he's feeling those kidneys, he's feeling for a large tumor, right? Because the tumor would have to be somewhat large to compress against the testicular vein, such that that's what would be causing the varicocele. And he must have felt it, right? Guy kept a straight face. You would never know, but he must have felt it, because later on when I found all this out, I would stick my hand deep into my diaphragmatic area, right below my diaphragm, and I would feel it, right? So he felt it. Anyway, so he orders an ultrasound. I get the ultrasound. A few days after the ultrasound, I get a call. Calls from the doctor, and the doctor says to me, he says, Lawrence, you've got a large tumor on your left kidney. Right. So now I hear that, and like I'm numb. Right. It's like it's registering, but it's kind of not. And he's like, it's the size of a grapefruit. So, I mean, I'm sure everyone out there can imagine, like, if you heard this, like, not only do you have a tumor, but it's the size of a grapefruit. Right? Can you imagine this? It's 14 centimeters. So he says it to me, and he says, look, we've got to get this looked at by a kidney cancer specialist. So, so many things are going through my mind when I'm hearing this, but ultimately I say, did you see it anywhere else? And he said, no. Right. And then, by the way, when they did the ultrasound, they did an ultrasound of the entire abdomen. So at least I breathed a bit of a sigh of relief with that. And he said, look, I said, so is it definitely cancer? And he's like, it most likely is, but we have to get it checked out. He says we could do he said we could do a biopsy. And, with the tissue sample, we'll be able to tell if it's cancer. Now, I said, well, I assume, irrespective of what the biopsy results are, and irrespective, right, of whether or not it's cancer, that this grapefruit-sized tumor on my left kidney, that it actually has to come out, right? There's no way this thing can stay inside, right? I'm assuming it has to come out. And the doctor said, absolutely, it's going to have to be removed. He said, along with the kidney. So now I'm hearing that, right? So I'm going to lose a kidney. So I said, well, then there's no need to do a biopsy, right? You can test the tissue once it's removed. Now, why would I say that? Why would I say there's no need to do a biopsy? Why would I even think that? I mean, doctor tells you do a biopsy, do a biopsy. Now, why I said this, it goes back to something my grandfather told me years ago in the 1980s. When his doctor had checked him out, it turns out that they wanted to do a biopsy on my grandfather because his prostate was enlarged, and they wanted to biopsy the prostate, get some of that tissue to ensure that that enlargement of his prostate wasn't, that the prostate wasn't cancerous. And he told them no. And the reason why he didn't want them sticking a needle into the tissue was because of a phenomena known as tumor seeding. Now, by the way, my grandfather, he was a big time skeptic when it came to the medical industry. He had seen so many issues with people in his family, with people in the neighborhood. He did a ton of research back then. No internet, right? So the guy bought medical books and subscribed to all of these alternative health newsletters back then, right? There were newsletters that they mailed you, and they got into like everything we would look at today on the internet when we want to dive deep. You would get back then by subscribing to newsletters and paying for newsletters. And he had stacks of newsletters, stacks of medical books, and people would always come to him with issues that they had to get his advice. And what he slowly saw, especially with people that got cancer, is that he saw a lot of things that disturbed him about what would happen when people were getting certain diagnoses and the way they were treated. And so it led him to become very skeptical about the medical profession and the healthcare sector. And he ended up putting a healthy dose of that skepticism in me. And so with that said, I'll get back to just give me a little bit of background here on, my mindset and kind of where it comes from, because I'm coming out of nowhere to my doctor saying, we're not doing a biopsy. And so what is this phenomena known as tumor seeding? So tumor seeding, it's also known as needle track seeding, is an issue that doctors will never talk to you about. And even then, if you bring up the issue, they'll push back and say, well, it's rare. But what it is, and by the way, I've discussed tumor seeding with some of my own doctors. And in all fairness, one of them actually acknowledged the phenomena, right? So he admitted, yes, it can happen. So here's what could happen. Here's what it's all about. What can happen when you insert a needle into a tumor during a biopsy is that as you retract, so you stick the needle into the tissue, it grabs some of that tumor tissue, and then as you retract the needle with the tissue, it can dislodge and spread cancer cells into the bloodstream. The interstitial fluid, which is the fluid around the cells, actually drains out into the lymph system. So when you're pulling that tissue out, right, cells, if it's cancerous, cancer cells can get dislodged and drain out into that interstitial, right? Dislodge, go out into the interstitial fluid, and then enter potentially the lymph system, or it can deposit those cancer cells, right? By the way, also the bloodstream. So it could come out, go into the interstitial fluid, leak out into the lymph system. It could leak out into the bloodstream. But it can also deposit those loose cancer cells along the track of the needle as it's removed from the body. As the needle's coming out of the body, there's this track that the needle's gone in, the needle's coming out. That's a track. And those cancer cells can kind of deposit themselves in that track, right? Now, in that tract, a tumor could develop because now there's a cancer cell there. And of course, if it leaks out into if those cells, those loose cells, if they get out into the lymph or into the bloodstream, if it is a cancer, it could metastasize, it could show up elsewhere in other places in the body. And this has been shown in studies to be a rare occurrence. So I will say that. And in the instance of developing a tumor along the needle track, right, they've found that this does happen. I've got the studies, but it's rare. However, there is no way to measure how rare the instance of metastasis is should there be a leak of those cancer cells into your bloodstream or into the lymph system, as there would be no way to know if the spread of your cancer to other sites in the body was the result of a biopsy you had. Because if those cells break out because you've ripped into that tumor and some loose cells get out, and if it gets into the lymph or into the bloodstream, and a year later you end up with a tumor somewhere else, you're never going to know if it came from the biopsy or not. You could certainly know if the tumor developed along the track of the needle that was used for the biopsy, right? When they pull it out, if that's where a tumor develops, you could pretty much guess that's why it happened. But if it shows up somewhere else, you'll never know if it was the result of your biopsy and those cells leaking out into the system. Again, your doctor's never going to talk about this. And of course, the needle track seeding itself is rare, but at the end of the day, who knows? It's something, look, it doesn't mean, and I'm telling you this flat out, it doesn't mean you shouldn't get a biopsy. All right. And it's something that you should discuss the risks of with your doctor. However, in my case, right, that was my reasoning for saying, hey, look, if the tumor has to come out anyway, there's no reason to even mess around with poking holes in it and potentially leaking those cancer cells out into the rest of the body. There's just no point. You're going to remove the tumor anyway. You can get that tumor. You can then test the tissue afterwards. So what's the point? Exactly. So keep that in mind, right? And by the way, there's more I can delve into on this phenomena because I'm just brushing over it right now. But one of the podcasts that we're gonna do based on what we're talking about here, we're gonna do a whole episode on the concept of tumor seeding and the risks of a biopsy. Okay, but my view is if you have a tumor, right? If I have a tumor and I've got to get it removed anyway, why mess with it? Why take the risk? Why take the chance? Remove the tumor, test the tissue after. Okay, those are my thoughts. So anyway, I interview some doctors, some surgeons, and ultimately, look, this isn't even something I need to question. Tumor has to come out. I get myself a good surgeon, and they remove the left kidney along with this giant tumor. Okay, so that's number one. I should also say, by the way, that when the scans came back, so I had the ultrasound. Then I go to see a specialist. They want to order more scans. They want to order MRIs. They want to order CT scans because now they want to make double sure the cancer is not anywhere else, and they want to get a better look at the tumor because an ultrasound, is only so good when it comes to imaging. Okay, so what do they find? They actually find that there's another tumor in my right kidney. So they find that there is a roughly 2-centimeter tumor in the center of my right kidney. And so that's not a place you want to be messing with when it comes to surgery, because in the center of the kidney, that's where all the veins are, that's right there in the center. That's where all the tissue and a lot of the tubules and vessels that are involved in filtering the blood. And that make all the vessels that make the kidney work. A lot of that action is right there in the center of the kidney. It's close to the ureter. You don't want to be cutting into the tissue there. Okay, so that's something that we're going to talk about in a moment, right? But the point is, we remove this giant tumor, and we'll deal with with what we're going to do regarding the other tumor in the right kidney, which again, that 2 centimeter tumor. We'll deal with that after the first surgery. So we get the surgery done. And then I sit down with an oncologist radiologist, right? So an oncologist who specializes in cancers that can be treated via radiology versus treated via drugs and chemicals. So I go to see this radiologist who tells me that, right, the way that we can deal with this tumor in the right kidney, and the way we can deal with it is something called ablation. We're going to do another podcast on this whole issue. So I'm going to kind of broad brush stroke over what happens here, because ultimately this concept of ablation is about this. It's about going into the tumor tissue, with a needle. But what they can do is they can enter the tumor and either with heat, which is called RF ablation, or with freezing cold, right? This is called cryoablation, where they release nitrogen gas. I believe it's nitrogen gas that freezes the tumor. And so whether they use heat, whether they stick a needle into that tumor with heat, or they stick a needle into that tumor and freeze it, it destroys the tumor tissue. And what they do is as they're doing this procedure, they're actually scanning the tissue, the tumor, so that they can see where it is. And then in some cases, they actually, especially with cryoablation, they watch the tumor as they stick the needle in, and it forms an ice ball. The ice ball envelopes the tumor, it destroys the tumor, and then later on, all of that tissue, it all evaporates. So it's all dead cells at that point. And so the radiologist says to me, hey, we can deal with this tumor. We stick the needle in there, we destroy the tumor, and that's how we'll deal with it. So I thought to myself, wow, that's fantastic. But I had the presence of mind to ask, well, okay, is there any risk to the kidney if you do that? And the radiologist says to me, well, there's a small risk. I said, well, okay, what does a small risk mean? And he's like, well, there's a small risk that you could lose the kidney. I'm like, okay, small risk. I could lose the kidney. He's like, yeah, there's a small risk that when we're in there, and he was, by the way, recommending cryoablation. So that was his recommendation, right? That we freeze it. And he's like, look, it could cause, so when we stick that needle in, when we freeze it, we could cause some bleeding. And if we can't stop the bleeding, and the bleeding is too much or too damaging, we would have to remove the kidney. So I said, okay. I said, what's the chances? Give me some odds on this. Like, what's the percentages? And he says to me, he thinks for a moment, he says 5%. So he said, there's a 5% chance you could lose your kidney from this procedure. So I said, okay. So, all right, let me think about this. All right. I've only got one kidney now, so I can't afford to lose both, end up on dialysis. So I got to think this through, right? Because what's my alternative here? And so, I asked him, what's my alternative? And he said to me, well, we can monitor it and see how it develops, because ultimately we don't have to do anything right now. It's not interfering with my kidney function. And, we can get a scan in another 3 months and see how the tumor is developing. Remember, this thing was 2 centimeters. The other tumor, and this is in the center of my kidney, it's really a messed up place to have it. The other one was on the outside of my kidney, and it was the size of a grapefruit, right? Much different. And who knows how long that tumor was growing to get to that size. But this one right now is 2 centimeters. And by the way, we'll get into what type of cancer I had as well on another episode, because we're going to dive deep into some things. And as we get to the end of this podcast, I'll give you the punchline as to why I decided it was time to start talking about this publicly. But ultimately, I thought to myself, you know what? let's take 3 months and monitor this thing. Let's not dive into anything right now. Can't afford to lose the kidney. Let's monitor things. I also want to rewind because I missed something that was really important. When I got that diagnosis the first time, when I got that diagnosis that I had this giant tumor, I was shell-shocked, right? 14-centimeter tumor, got to remove the kidney. I don't even know I have the smaller one on the other kidney at this point. But I was literally in a daze when I heard this. And, I had to tell my wife, I had to tell my family, my kids, and man, if anyone's ever had a cancer diagnosis, you know what I'm talking about, but you go down a dark rabbit hole. And, I was, all I was thinking about, it's the worst feeling in the world. It's the worst feeling I've ever had, worst feeling I've ever experienced. I've experienced some bad stuff throughout my life, but I could say that hearing this information was the worst pain, the worst psychic pain, certainly, that you can imagine. It was a sickening feeling in my gut that my kids and my wife will no longer have me should this go wrong. And, first thing you start thinking about is, how long am I going to live? And, I wasn't even really thinking about myself. I was thinking about not being with my children and my wife any longer. And that even worse, that, they rely on me, and like my kids aren't going to have their father. My wife won't have her husband anymore. She won't have me anymore. And this will be devastating to them. And so that's all I could think about. And I went down a rabbit hole, man. I went down a dark rabbit hole, and it was horrible. And the next day, can you imagine if you have to think this way for, so, there's so much, like if you get a diagnosis like this is something there's something you're thinking about a lot. Can you imagine having to face this reality over and over again every day for even years on end? So it was a nightmare thought process. But the next day I got into my office and I thought to myself, I always get into the office very early in the morning. I was in very early, and I thought to myself, I'm going to defeat this thing. I'm going to fight this thing. How do I do that? And so I got online and I typed in, I remember clearly, I typed in how to defeat cancer. And then all this information started coming up. And all of a sudden, I started diving deep into a lot of research, and I started feeling immediately better because all of a sudden I saw a light at the end of the tunnel. I saw hope. I saw that potentially I could have some control over my fate, over my destiny, and over this cancer, over this diagnosis. And, two things jumped out at me immediately, and they were how to deal with your cancer through diet. And again, we'll get into other podcasts about this, but suffice to say, and there's many other things I uncovered along the way, but the two big things that jumped out is that you could deal with this diet, from a nutritional standpoint in two ways that I could deal with this. And there was a vegan rabbit hole and a ketogenic rabbit hole. And that ketogenic rabbit hole, ketogenic diet, everyone's heard of the keto diet, or maybe you haven't, but if you haven't been living under a rock, you've heard of it. The ketogenic diet could be done as a vegan or as a vegetarian as well, but it could also be done with meats and animal fats and and that kind of thing. So there were two roads nutritionally that I could go down. I'll just say up front, I certainly went down the ketogenic approach, and I did not go down the vegan approach. I went down the meat and animal fat approach. And so that's all I'll say about that for the moment, right? But I just want to put this message out that if you've had a diagnosis, or if you get a diagnosis of something that's life-threatening, if you get a cancer diagnosis, take heart that there is some form of control you can exert over your fate and your destiny, and that there are things that you can do outside of whatever's prescribed for you. There are things that you could do that will give you control, that will give you an edge in fighting cancer, and that will have an impact on what ultimately happens to you. You got to do your research. You got to dive in. You've got to experiment, and you've got to find what's right for you. But there's a lot of things that you can do. And it's not a lost cause. It's not a death sentence. It's not, it's not doomsday. No matter what you're told, there is always hope. There is always a way. And you gotta start down that journey, because the more you learn about your cancer, the more you learn about your condition, and the more you learn about what you can do about it, the better you will feel. Because the minute you find something that you can latch onto, some form of research, some information that can give you some form of control and some form of making an impact on your condition, the minute that happens, the minute you gain some knowledge on this, you'll feel better. Because that's what we all need. We need hope, and we need a path. And, don't count on, don't count on someone else to simply guide you on this path. Take information, right? Take insights. Certainly take your doctors and your medical professional, your healthcare professionals' insights and advice, but do your own research. We'll get into this more, but I just want to let you know that besides what you're told from your doctors, right, it's important that you also take part in the journey, and that you do research, and that you look into things as well that can help you. It's not just in the hands of your doctor. You're a tag team with your doctor. You got to partner with your doctor, right, and bring something to the table, right, to help impact your condition. The minute you do that, you're going to feel like there is a way out. You're going to feel like there's a path forward. You're going to feel like you have a chance. Okay, enough of that. Anyway, tumor ablation, destroy the tumor in the right kidney with either heat or with the cryoablation, the freezing cold. But again, I opt, hey, you know what? Let's just monitor this thing. I'm going to do what I can do on my end. Right. I'm going to definitely go on this ketogenic diet. I'm going to go on this down this path, but let's watch that right kidney. Let's not jump into getting in there and doing anything at the moment, because there's a 5% chance I could lose my kidney. But, then I say to myself, okay, well, hold on a second. Let's back up what's just been told to me. This radiologist is saying, hey, 5% chance, and he's saying we could deal with this. And before I make my decision on how to proceed, right, so I'm doing some research. There are things I can do. Certainly not comfortable necessarily leaving this tumor inside of me on my right kidney. I certainly want to deal with it, but at the same time, I'm concerned, could lose the kidney. Let me get a second opinion, right? Get a second opinion. So I then spend a lot of time looking for experts when it comes to kidney cancer, because I want to speak to another kidney cancer specialist, about whether or not I should have this ablation. And we're going to do a separate episode on, because I've I end up having, I've spoken to a lot of doctors, right? And if anything comes out of this podcast, I implore you to get second opinions and even third opinions on anything that you intend to do when it comes to treating any condition you have, right? I know a lot of stories, and I'll speak about one in particular, not right now, about just leaving it all in one doctor's hands, getting your diagnosis, blindly following that diagnosis without doing any of your own research, without getting any second opinions. If you do that, if the advice is bad, because let's face it, these doctors aren't gods. Some of them are worse than others. Some are great, but just like any profession, you have the best of the best, and then you have everyone else. And if you happen to be in the hands of a doctor who might not be that great, or might not be up on the latest research, or might not know what he's doing or she's doing, and you don't get a second opinion, you don't get a third opinion, you don't do your own research, then you're putting your life in your hands. Okay. And I'll tell you a story, not in this podcast, about one such event. And I have a completely different story about another such event with myself. But for the moment, just sticking with this particular situation. So I do a lot of research, and I look for, I'm looking for the best of the best in the marketplace. And we're going to do a separate podcast. As I said, we're going to do a lot of separate podcasts, but we're going to do a podcast where I'm going to show you my methodology for finding the best doctors, because I've had to do this. And over again, I have found the best of the best doctors. And there's a method I have for doing that, right? It's not going on Google and looking at how many stars someone has and reading their, reading their reviews by patients, although don't get me wrong, that's good. And that's a backup thing, but that shouldn't be your primary method for finding great doctors. So I have a method for finding great doctors. I'm going to share that with you on another podcast, and hopefully that will really help you. But again, I'm going off on a tangent. I do my research, and I find one of the best doctors when it comes to kidney cancer. And at the time, by the way, I was living in London. When all of this was going on, by the way, I was living in London. I wasn't living in the United States. I was living in London. So I find the best doctor in London when it comes to kidney cancer. And I see the doctor, and we go over my entire case. I go over my concern about the tumor in my right kidney and about what I've been advised to do. And the doctor says to me, under no circumstances should you have the ablation. And I'm like, oh, this is interesting. And I said, why not? He said, look, the risk is not 5%. He says the risk, especially with respect to where your tumor is located, he said the risk is much higher than that, much higher. He says, and if when they do that ablation, they damage the tissue around the tumor and in the center of your kidney, and there's a high likelihood they will, that there'll be bleeding, and that there'll be damage to that tissue, the inner workings of the kidney. There's a very high chance you could lose your kidney, and you only have one. And and another thing he said to me was that, look, we typically don't do chemotherapy for kidney cancer because it's been shown to be mostly ineffective. He says to me, but if there's no other options, and, there are some things we could do, we're going to need that kidney intact. So I'm like, oh, fucking great. So, and by the way, I'll say up front, that I've done another podcast, on chemotherapy, right? I've done that. I did that a couple of years ago. I'm not a fan of chemotherapy. I'm not a fan of radiation. I'll explain why in another podcast. But when he said that, I thought to myself, well, I'm not having chemotherapy anyway. But that's, again, this is my opinion. We won't get into that now. But the point is, that was his thought process as to why they want to keep the kidney intact, right? So that it's there to absorb and to filter the drugs that are going to, the toxins that would come from having to do any form of chemotherapy. And he also, look, the reality is they don't treat kidney cancer for the most part with chemotherapy. If they treat it, they treat it with checkpoint inhibitors, targeted therapies, immunotherapies. There's particular drugs that target based on certain mutations, and again, we'll talk about the type of kidney cancer I have shortly. But for the moment, I've now got one of the best doctors they're telling me, don't do it. Okay, so now I have a second opinion. And I feel a lot better about not messing with the right kidney for the moment. But I think to myself, well, I might not have a choice. And that was his point as well. He's like, look, right now, you don't need to do it. Monitor this thing and see what happens. Ultimately, the thinking is that at some point, you might not have a choice and you might have to do it, because if the tumor gets too large, you can't leave it there. It's going to destroy the kidney anyway. At least let's take a chance and then we'll deal with it. Makes sense to me. So what do we do? I think to myself, all right, I've got one doctor telling me, do it. It's a good chance, 5%, it'll be fine. The other doctor telling me, who's not a radiologist. So this doctor is, so the first doctor was a specialist, a radiologist who specializes in ablation for cancer, for tumors. The second doctor is an out and out surgical oncologist. And he's saying, don't do it. Right. And you could think, well, surgeons don't want to do ablation. They want to do surgery. Right. But nevertheless, look, this is a top doctor in the field. All right. So now I have that doctor saying, don't do it. I have the other doctor saying, do it. Let's go for a tiebreaker. So I dive deep into the literature and I said to myself, why don't I just find the best of the best in the ablation community in the UK and speak to that person. So I actually end up finding the pioneer of cryoablation in the UK. And I somehow get through to this doctor, and I get to have a consultation with the #1 cryoablation specialist in the United Kingdom, and regarded within the kidney cancer community around the world is probably the foremost specialist when it comes to cryoablation for kidney tumors. So this is who I found. This is who I speak to. And this doctor says to me, we can do it. He says, I explain, I got the two differing opinions. And he says to me, we can do this. And very, very, very small chance that anything would happen to the kidney. He feels extremely confident that we could do this successfully and that there won't be any issues. So right now I have that individual telling me, okay, we can do this and we can be successful with it. So I'm like, all right, thank you. Let me think about it. And my thought process after thinking about this was, hey, all right, now I have the best of the best when it comes to cryoablation. If I'm going to choose that route, if I'm going to do any ablation, am I going to do cryo? Am I going to do heat? But I've got the best of the best telling me they can do it. And I think to myself, okay, here's what I'm going to do. I'm just going to monitor this tumor. I'm going to see, using my own protocols, like diet, like the ketogenic diet, like intermittent fasting, a few things. I'm going to put a few things into play. Every 3 months, they're going to want to do a scan on me anyway for the first year. Let me monitor this thing. And if it gets to a point, if the tumor, my right kidney, gets to a point where we need to remove it, okay, I've got the best in the world at cryoablation that I can go to and get this thing dealt with. But why take the risk at the moment? So that was my thinking. We're going to monitor it. We've been monitoring it, I should say, now for 7 years, and it hasn't gotten that much bigger. Pretty much the same size it was originally. And so I haven't had to remove it. Thank God. I haven't had to deal with it. I haven't had to have ablation. But when I got to the United States, I came home from the UK after spending a number of years there. And, a couple of things happened. One, another tumor developed on my right kidney, no longer in the center, this time on the upper pole of the kidney, on the outside. And I've been monitoring that. I found that one came about. We found it with a scan in 2018. So about 4 years ago, we noticed there was a new tumor on the kidney, and the first time we noticed it, it was about 1 centimeter. It's now gotten up to about 2 centimeters, and it's kind of stabilized around there. So now I have 2 kidney tumors that we're monitoring. But again, I'm not messing with it until I don't have a choice. But here's the thing. The thing is this: along the way, as this other one was growing, and as I was monitoring everything, I thought to myself, look, I might need to have this ablation. I'm no longer in the UK. I'm here in the States. And so I interviewed 3 different ablation specialists here in the States. And again, I used my method for finding the best of the best. And I ended up interviewing 3. Why? Because one of these doctors, one of these specialists, tells me we're going to do it with heat ablation. And another one tells me we want to do it with cryoablation, right? So one with heat, one with freeze. And so once again, I find myself in a quandary. One says heat, one says cold. And ultimately, I get a third opinion. And this is, again, why I implore everyone out there. It is crucial that you get second and third opinions, because I'm most likely thinking I'm going to go with cryoablation, because it seems like there's better outcomes. It seems like because they can monitor the tumor as they're performing the ablation with heat. Once they stick the needle in, they're not really scanning it, because you can't really see the tumor being destroyed, right? You don't really see anything. The thing with so they use an algorithm to dial into the heat ablation. They use an algorithm to decide how much heat to give it, and based on that, right, what they do is they then do a final scan after it's over to see how much they got of it. But they use an algorithm to decide how much of the tumor to destroy. And, they try to go for a rim outside of the tumor. They want a margin outside of the tumor. And so they plug in an algorithm. The cryoablation is a lot more precise. Why? Because when they stick that needle in, they monitor, they actually watch with a scan. They're actually watching the ice ball develop. And as the ice ball develops, right, they see it envelope the tumor, and they see it come outside the margin of the tumor, and then they stop. So they can watch this happening because the ice shows up on the scan, right? Heat doesn't show up on the scan. The ice shows up on the scan. And so they can watch it happening. So I'm thinking to myself, I'm going with cryoablation. I go with a third opinion. And the third opinion doctor, another expert. And by the way, each one of the ablation specialists that I speak to, each one of these doctors are absolute top notch in their field. The third one I speak to actually admits to me the phenomena of tumor seeding when I can, and as I've confronted the others with it, right? They pretty much dance around it. They don't say much about this idea of the needle goes in, the needle comes out, because if the needle goes in with a biopsy and it comes out, right, and it could dislodge tumor cells, well, certainly with an ablation needle, if it goes in and comes out, it could dislodge tumor cells. The thinking, though, is there's a lot less risk with that. Why? Because, right, the heat as it comes out will destroy, the heat will destroy any tumor cells, and the freezing cold will destroy any tumor cells. So it's a lot different than just a straight up biopsy where there's no heat, no cold, just the needle comes in, needle comes out. Tumor cells could possibly come out of that, leak into the lymph system, leak into the bloodstream. But with an ablation, those cells, you're hoping, right, they're all going to perish. So, but what this doctor tells me, he admits to the fact that it can happen, that there is, yes, tumor seeding can happen. He says it's rare, but he actually talks to me about it. But here's what he ultimately says. He says, Lawrence, he says, the reason we don't want to do cold here and the reason we want to do heat ultimately is that when you remove the needle, and actually with cryoablation, they use 2 or 3 needles. With heat, they use 1. But with cryoablation, they use 2 or 3 needles. When those needles go in and come out, he says that there is a chance that some of those tumor cells survive the freezing cold. But with heat, he says nothing survives the heat. And when that needle comes out, the temperature that it's been ratcheted up to, he says nothing's going to survive it. Nothing survives it. No cells. He says with the cryoablation, in his opinion, he says the cells might survive. And then he says, yeah, there is a risk. So again, I hope some of this information happens to help. But I'm going to kind of round out this podcast with why I decided to finally come out and talk about everything I've learned about. It's because in May of this year, or June, somewhere May or June, in monitoring my kidney tumors, they found that a tumor showed up in my liver. Right, so almost 6 years to the day, they find a tumor in the kidney. And I should tell you, as they're monitoring me, because I get scans now every 6 months, as I get these scans, we can see little things happening here and there. And I've had a lot of false alarms. Well, not a lot, but I've had a few false alarms where they've seen something and it turned out to not be anything. But over the course of time, they see a little something develop in my liver, and the notes on the MRI report come back, maybe 7 millimeters. We see something that's 7 millimeters. It's probably a cyst. Comes back again that they see something that's maybe 1.1 or 1.2 centimeters now in the liver, probably a cyst, it says. Comes back again, 1.8 centimeters. And they're like, hey, maybe this isn't a cyst. And so here's what happens, because so we get back to this biopsy option. And I should also tell you something else that might help you. I'm having all of these scans, MRIs. I stopped having CT scans because of in my opinion, from my research, there is a risk, especially as you get older. Well, it's the same risk when you're younger, but you should certainly be more cautious when you're younger, because as you have these CT scans and the amount of radiation that CT scans put out over time, depending on how many of those things you have, there are studies as to how they impact how long you live, right? Because this is a serious amount of radiation, a CT scan, and 1 is not a big deal, 2 is not a big deal, but if you're having them every 3 months or every 6 months, they start to become an issue. As you get older, they're less concerned about it because of the equation. They do an equation. They're like, well, if you don't scan it and you don't use the CT scan, maybe you won't find something in that, and even if even if you do find something, if we don't monitor it, we don't have a good look at it with the CT, then there's a risk that, obviously, there's a major risk that things can go wrong, as they don't have the capacity to monitor it as effectively as they could because of the contrast and the imaging of it all, and that could lead to a serious situation. But the reality is, if you're older, what do you go with? Do you go with the risks of excessive radiation from the CT scans versus having good monitoring, right? The radiation will end up shortening your life, but not catching the tumor and not seeing it in the right way, that'll kill you a lot faster. So that's the equation that's done when you're older. But the reality is this: I stopped having CT scans. I stopped having them for a long time. I didn't have a CT scan for 4 years. I finally had one again when they found the liver tumor, just to do a CT scan of the lungs, see if anything's there. Fortunately, they didn't find anything. But I'm trying to because of all the scans I have to do, I'm trying to minimize the amount of radiation I'm getting. Anyway, I have studies on this. I have studies on the fact that CT scans over a period of time do impact lifespan. That's another issue for now. The point I want to make is about all the MRIs that I have. With the MRIs, they want to give you contrast. Typically, it's a contrast known as gadolinium. We'll get into a whole podcast on this particular issue as well. But in short, I do not have the contrast when I have these scans. Why? So I got to a point where I had so many scans throughout the last 7 years, I started to notice a correlation between having the MRI and having the contrast that they inject, this gadolinium, right? Which, I noticed a correlation between after a scan for a week or two, I would slur my words. Sometimes I would, and I do a lot of speaking for my profession. And when I'm speaking, I would notice that I would slur a word. And I started noticing it would only happen in the 2 weeks following one of these MRI scans where I have the contrast. And it turns out gadolinium over time collects, it ends up collecting in the brain, and over time can cause neurological issues. So I thought to myself, that's it, I'm done with the contrast. And so I stopped having contrast. And the doctors tell you they want to do an MRI scan with contrast because they want to have good imaging where, again, the term is contrast, where they can see the tumor tissue and they could see it against the other tissue, and they get a better picture of it, but they also get a better picture of the inside of the tumor. And it lets them know, among other things, whether or not a tumor is solid or filled with fluid. That's important because in my case, when they found the tumor in the kidney, when it got to 1.8, I'm sorry, when they found the tumor in the liver, as it got to 1.8 centimeters, 2 centimeters, the key here is, hey, is this thing solid? Because if it's solid, it's likely a cancer. If it's filled with fluid, it's likely a cyst. And so again, I don't want to get a biopsy. So I told my doctor, look, I don't want a biopsy on this thing. I explained the reasons why. And you know what? Didn't argue with me at all. He says, I get it. Right? No problem. He said we could tell if it's a tumor if we do the scan with contrast. It'll tell us if it's solid. So that's what we did. We had another scan with an MRI, this time with contrast, and it was solid, right? So, okay, we got to do something about it. I found the best surgeon, top surgeon in my area. And again, I spoke to that surgeon. I said, hey, look, I'm not biopsying this thing. Let's just remove it. Then you'll have the tissue and we can look into it. You could test the tissue, because now the question here is, hey, is that cancer that's in my liver now? Is that a metastasis from the kidney? Is that the kidney cancer that's gone to the liver? Or is this another cancer? Like, is this right? Like, is this is it a melanoma that's moved to the liver? Is it a colon cancer that's moved to the liver? Or is it fucking liver cancer? I mean, it's like dealer's choice. What is it? So the question is, should we biopsy it? No biopsy, right? We'll do the scan with contrast. We'll find out if it's solid, and then you just remove it from me. No biopsies, test the tissue after the fact. Surgeon didn't have an issue with it at all. We don't need to do a biopsy. And he didn't argue with me at all. Didn't say we need to do a biopsy. He said, in fact, he's like, I understand completely. When I explained why I didn't want for him to poke a hole in that tumor in the liver, he understood completely. So they know, they get it. They just don't want to talk about the risk. And, so that's a whole nother issue. Okay. So, and again, when I get this diagnosis that, hey, there's most likely now another cancer in the liver, and that it's potentially the kidney cancer is metastasized. Because I've been dealing with this for so long, and because I have a very positive attitude, and because I am personally looking at making an impact on my health and taking control over my health, I didn't go down the rabbit hole again. In fact, I was absolutely fine when they told me I had this thing in the liver and that it was solid, and that it was probably cancer. And the only question is whether it's the kidney cancer or some other cancer. I'm telling you now, completely positive. Again, fighter's mindset. We're going to knock the shit out of this thing, and we're going to continue to find ways to deal with what I've got. So, okay. And the other thing that I hope in sharing again is that back to the MRIs, and this guy skipped over something. The reality is what I figured out is you don't need to have contrast, especially I don't need to have contrast, right? And I don't need to have the contrast because, look, if it's building up over time in the brain and could cause neurological issues, and certainly I'm having issues. I'm slurring my freaking words for 2 weeks afterwards. If I'm noticing an impact, and they'll tell you that there's no risk with gadolinium. I've done the research. We'll have a podcast on this. There are risks by constantly having these monitoring scans where you're getting gadolinium that they use. That's the contrast element that they use. There are issues with it. There are risks, neurological risks with it. So we'll do a podcast on it. But here's my point. My point is, if what we're doing is simply monitoring a tumor over time, then you don't need contrast to see if it's grown. Let me tell you something, they can find tumors with today's MRI technology. They can find tumors in the body without contrast. They don't need contrast to see a growth, to see a mass within the body. And they could see these masses in your body in the millimeter range, even without contrast. That's how good the technology is. So you don't need contrast for that, right? If you're just looking for something, or if you're monitoring the growth of a mass in the body, then you're fine. You don't need the contrast because the scans will tell you how big it is, and they'll tell you how big it's getting. And so armed with that knowledge, why do I need the contrast? Why do I need to constantly take the contrast? They want you to take it because it gives them a better image, but do I really need it? Is it worth the risk? Especially when you're having tons of these things. If you can have one of them here and there, it's not a big deal. But because I'm having so many scans over the past 7 years, that's why. So it's important to note that these scans can detect a mass in the body in the millimeter range without contrast. It's important to know that. And gadolinium as a contrast agent does pose risks to your neurological health. Again, we'll have another podcast on that, but that's what I'll say about that for now. That's not to say that you, if you're listening to this, should avoid having the scan with contrast. Have it with contrast. Listen to your doctor on this, right? Don't take my advice on this. I'm just telling you my opinion for me. Here's what's best for me, right? You'll have to decide what's best for you. And again, speak to your doctor about the risks. Do your research about the risks. And again, if you're just having a scan, a one-off here and there, it's not a big deal because you probably won't have any issues. Although there are people who are flat out allergic. There's an allergic reaction to these contrast elements as well, and you won't know until you get it. So anyway, okay, so we got the tumor in the liver. We get the surgery. They remove, it's a 2-centimeter tumor. The surgery is a success. After the surgery, we had the tumor sent in for genetic testing to uncover what particular mutations might be afoot, right? They did a first level pathology on the tumor to see what kind of cancer it was. And initially, within the first week, they came back and said, hey, it's the kidney cancer, right? So it's the same thing you have in the kidney. It's not a different cancer. So thank God I don't have to worry about dealing with two different cancers now, right? So it's still the kidney cancer we're dealing with. So now we're going to have further genetic testing to see what potential mutations are afoot, if any. So I make an appointment with the oncologist to discuss possible drug strategies. If not for now, and again, I'm not taking any drugs right now, but hey, maybe for the future, in case they might be necessary, in case the tumor pops up somewhere else, in case a cancer pops up somewhere else, this kidney cancer, and if it pops up somewhere else in the body, such that it's not so easy to deal with when it comes to surgery, I want to know what potential drug strategies we have. Not chemotherapy, not radiation, but what kind of targeted therapies are there? So that's the reason I make the appointment with the oncologist. That's the reason why I have the genetic testing, to see what is possibly afoot, to see what else I can learn about this tumor. We did they did the genetic testing on me when I was in London, but when I moved from London back to the States, I ended up not getting access to the to the testing and finding out what the results of it were. That's kind of okay. I didn't need to use any drugs. I wasn't going to be using any drugs. Again, we were just monitoring how things were going for the time being. And so fortunately, I never really needed to leverage the results of that genetic testing to see if there are any targeted therapies that could be used. So this time, now I'm here in the States, let's have the genetic testing. Let's see what we can do. And so I'm going to go into what the genetic report ends up telling me. I'm not going to do that now. I'm going to do that on the next episode, but suffice it to say that I go to the oncologist. We get the genetic, the molecular testing results. I go through it. I research all the results. A few mutations were found. And of those there was definitely one, right, that is associated with the type of kidney cancer that I have, and that there are targeted therapies for. And so I did that research prior to going to the oncologist. I really dove deep. We'll go over what I found in the next episode of the podcast, because here's where it gets interesting. Because when I go to see the oncologist, they tell me, yeah, we see these, we see this mutation in, the gene here that is related to your type of cancer. However, the type of kidney cancer you have, the targeted therapy we have for that mutation hasn't been shown to work. And the oncologist ultimately ends up telling me, we spent about 45 minutes together, but ultimately the upshot of that, the outcome of that session is this. For the type of kidney cancer I have, and I'll tell you now, it's called chromophobe kidney cancer. That's what as opposed to renal clear cell cancer. I have something, it's a rare form of kidney cancer called chromophobe renal cancer. Now, we're going to get into this again in the next few podcasts, because things get wild. Things get really interesting. But the reason I'm on today talking about this and sharing my experience with you is because the oncologist tells me that the type of cancer you have there are no targeted therapies for it. Because the targeted therapies, even though you have this, apparently you have this mutation, we see this mutation from the molecular testing, the targeted therapy that works with that mutation hasn't been shown to work in your type of cancer, in chromophobe cancer. In fact, with chromophobe cancer, they tell me there are no drug therapies that have been shown to be effective. So essentially, the oncologist tells me your strategy of surgery or ablation, that's the right strategy, stick with it. And, that's it. It said to me, you're on the right path. Surgery, ablation, that's the way you deal with this, because no targeted therapy, no chemotherapies, no drugs are effective with this type of cancer. That's what I was told. So, having been told that, I decided, am I going to accept that, or am I going to do my own research? And I did my own research, right? And what I found when I dived into the research on my type of cancer, what I found is that there are indeed strategies, drug strategies, that can absolutely be employed based on scientific studies that have been done, right? I discovered there are a number of possible drug strategies that can be considered, and I mean from a scientific standpoint, backed up by studies directly from the medical literature. I'm not talking about alternative treatments at some clinic down in Mexico. I found in my research some very powerful possibilities that might be applied to my particular cancer that were never mentioned by my oncologist. And that's why I'm here today, going through my experience among some of these other issues that hopefully you found interesting, whether it was the issue about the biopsies, which we'll get into in much more detail on another podcast, whether it's about the contrast and the gadolinium, right? Whether it's about anything that, the second and third opinions that you have to get, any of this that I'm sharing with you, I hope some of this helps you. But ultimately, the reason I'm here with you today, the punchline of this whole thing is that I was told by my oncologist, who, by the way, I did my research. I chose my oncologist. I didn't take the recommendation of my surgeon. I looked through, I did my research. And again, that's a whole nother podcast we're going to have. Like I said, I hope to help you there by with a method and a process, finding the best of the best doctors for your particular type of cancer or your particular type of condition. But the research I did, I found one of the best oncologists in the field. And this oncologist ends up telling me, no drug strategies for this, right? And that's great. But if the cancer comes back in a place that you can't really do surgery on, then what? Am I screwed? But from my research, looking through the medical literature, looking through the scientific studies, right? This is what I want you to know, right? Is that, and this is the key, beyond any particular drug strategy that I've uncovered, my ultimate point for you to consider is to never abdicate your responsibility to question, to probe, to investigate, to ensure that you are getting the best care and treatment possible. You cannot accept what one doctor says about anything without getting a second and possibly even a third opinion. And just as important, if not more important, as far as I'm concerned, is that you must vet the doctor's opinions by doing your own research, as no one cares more than you do about your predicament. And no one can or will devote more time to investigating and addressing your condition than you. So on the next episode of the Alpha Human Podcast, we're going to dive deep into what I uncovered, into what I saw from the particular mutations that the molecular testing identified, to what I found in the literature, in the scientific studies, in the scientific papers about my type of cancer, and about the treatments, the potential treatments for this type of cancer. What I found is absolutely major league impactful, mind-blowing impactful, what I found. What I found is absolutely, it shocks me that my oncologist did not at least describe for me the research that's being done and some of the possibilities that are out there. And so that's what I will leave you with. All right. On the next episode, we'll dive into it. We'll dive into what I found. We'll dive into why your oncologist might not necessarily even know, no matter how good they are, about all the possibilities and about all the treatments that are out there. And we'll dive into why, again, it is so important that you not abdicate your responsibility to your own health, become an absolute player, become the conductor, become the quarterback of your own condition, right? That's absolutely key. Absolutely key. No one's going to care more about your health than you do. And no one, and this is what I have found through my own experience, no one is going to devote more time to investigating or addressing your health issues than you. You care most about you. You will take the time, and I've taken the time. I spend 2 hours a day, every day, super early in the morning, doing my research. I've looked at I've read hundreds upon hundreds of studies. And I'm not a doctor, I'm not a scientist, but I will show you why anyone out there, why you can take the time to do the research and read the papers and understand your condition in a way that might just provide you a path. With that said, I hope you have a great day. This is Lawrence Rosenberg signing off from the Alpha Human Podcast. Go forth and remember the logo behind me, victory through insight. Take care.